And during this time, attend and organize this meeting, it's really a challenge for us. But in spite, we thought of continuing such academic program, and that will benefit our postgraduates, and they can refer it anytime from the YouTube. Coming to today's topics, we have two topics. One is anesthesia breathing circuit by Dr. Baburaj C., who is the professor, Government Medical College, Trichy. Dr. Baburaj is always, people like to hear from him because he presented it in a very nice and interesting way, and a well-known speaker from the state. I'm happy to welcome Dr. Baburaj to today's meeting. The second part is the drug discussion on the drug. I think we are discussing on general anesthetics and benzodiazepines. Dr. Sanish PJ, who is the senior consultant at Anandapuri Hospital, Tirunelveli, has prepared this topic in an excellent way to make it much attractive with a lot of interactions in between this. Dr. Sanish, I'm happy to welcome you to this meeting. I take this opportunity to welcome our National President-elect, Dr. Venkatagiri, who is always the inspiration for us, all our academic activities, and guide us in all our efforts to organize it in an excellent way. Also today we have our senior teacher from Mumbai, Dr. R.P. Gadu. Sir, I am really happy that you are with us this evening and welcome you to this meeting. I welcome all the senior teachers. I welcome all the delegates and senior officials to this meeting. Now over to Giri for a few words as the opening remarks. Dr. Giri, please.
Good evening, President Dr. Nazar, Secretary Binil, faculties Dr. Baburaj sir, Sanish, and President again as a faculty, and our good friend and senior consultant Dr. Dedu sir, and all friends and PGs. We are continuing this program evening, and many are waiting for this. So good that we are able to continue with good number of participants. Again, today we have the good topic of breathing circuits with the Baburaj and drugs by the Sanish, who are both very popular teachers and attract many participants. It will be benefit for everybody, and more people will join. Many may be busy with managing COVID and all. Maybe in due course of time, more people will join and see that. So, without talking much about it, I welcome all the delegates, and also I wish that Rajesh and Vijay are trying hard from their level to get good speakers and good faculty and make it more interesting and useful for the PGs. Thank you, and over to you, team, Binil and
Okay, thank you, Dr. Giri. Now we straight away go to the academic part. Please, Dr. Rajesh MC, who is the scientific chairman, ISA Kerala State Chapter, and Dr. Vijesh Vanubal, who is the governing council member of ISA Kerala State Chapter, to take over the academic proceedings. Over to Rajesh and Dr. Vijesh, please.
Thank you, Nasser, sir. Good evening, everybody. For the first talk, we have with us Dr. Baburaj. Baburaj, sir, is the professor of anesthesia at Government Medical College, Trivandrum. He's a well-known speaker and he's known to all of you. He was there with us previously also. And over to sir for his topic. And I would like to ask the PGs to put in their questions within the chat box. And sir will be there with us at the end of both the talks for giving you the answers, because he's right now he's slightly busy and he's held up. So at the end of Dr. Sanish's talk, Dr. Baburaj sir will be there with us, and he will be taking your questions and he will be giving you the answers. So all the PGs, please put your questions into the chat box. So over to Baburaj sir.
Respected ISA leaders, respected teachers, and dear friends. An anesthesia breathing circuit is an integral part of an anesthesiologist's armamentarium. The circuit delivers oxygen and anesthetic gases from the machine to the patient without altering its composition. There is one more function for every circuit, that is elimination of carbon dioxide. The carbon dioxide exhaled by the patient can be eliminated in two methods. One is it can be absorbed with a carbon dioxide absorber, which is used in a circular system. Or secondly, this carbon dioxide can be made to exhale by manipulating the fresh gas flow as well the structure of the anesthetic circuit. We move on to the Mapelson's classification as a circuit, and he is Professor Emeritus William Wellesley Mapelson. Remember, he was not a doctor. He was a bachelor holder in physics who joined the National Medical School, Cardiff, as a research assistant. But he became professor and he retired officially in 1991. And he published over 100 papers on wide range of subjects and mostly on the anesthetic drugs, especially inhalation anesthetics. And his name will always be associated with his early work on classification of breathing circuit, the Mapelson systems A to E, which he has done in 1954. And he was awarded FRCA in 1996. Let us move on to Mapelson classification. I already said in 1954, Mapelson did a thorough analysis of the available breathing systems and classified as A, B, C, D, and E. That doesn't mean that these circuits were non-existent before 1954. It is not so. Actually, the Magel circuit, that is Mapelson A, was there in 1930. He invented in 1930, Ivan Magels. And Philip Ayer invented ISTPs in 1937. And the Bain circuit was introduced in 1972 only by Brain and Sperrel. Similarly, Jackson Rees has invented the JR circuit, which was included in this Mapelson classification by 1975. And after 1 year, Dr. A. Lack invented the Lack circuit, which is a modification of Mapelson A. Now, what are the components of breathing circuit? Fresh gas inlet is actually carrying the fresh gas from the anesthesia machine to the circuit. And then comes the reservoir bag, which is also known as breathing bag, which is acting like a reservoir. And breathing tube is also functioning as a reservoir, and its the major function is to convey the inspired and expired gases to and fro. And there is an adjustable pressure limiting valve. Let me tell you something about APL valve. See, APL valve has a disc which is held in place by a very weak spring. No, it is not a strong spring. The tension of the spring can be adjusted by a screw mechanism. Look at this picture. You can see the disc here. When the valve is in fully open position, the tension on the spring is very minimal. So this open position is used whenever patient is spontaneously breathing. Look at this picture on the right side. So when the valve is fully open, the disc can be easily opened up by a minimum pressure developed in the circuit. So whenever patient is spontaneously breathing, the APL valve should be fully open. But the disc will remain closed in the aperture, which will be raised by a slight increase in pressure inside the circuit. And when the controlled ventilation is done, usually the valve is in the partially closed position. 2 points which are of importance are, in the open position, the valve will be opened by a pressure of around 1 centimeters of water. That means that much resistance will be offered to the patient's expiration. Okay, mild. But when valve is fully closed, totally closed position, still the disc can be opened at a high pressure of 60 centimeters of water. This is actually a safety measure. So I repeat, when the patient is spontaneously breathing, valve is kept in the open position. And when the patient is under controlled ventilation, the valve is in the partially closed position. We will never keep the valve in the fully closed position, always in the partially closed position for controlled ventilation. Now, what about the gas composition in a breathing circuit? This is also very much important. Actually, this gas composition determines how much rebreathing happens, how much gas is wasted and going out of the atmosphere. One is the fresh gas, which is coming from the machine. It is dry, there is no humidity, there is no warmth. And second gas is the dead space gas. See, dead space gas can be apparatus dead space and the anatomical dead space. So the gas coming from the anatomical dead space is humid. It is warm. As there is no gas exchange happening, this dead space gas doesn't contain any carbon dioxide. So it is far better than the fresh gas coming from the machine because of the humidity and warmth. And the third gas, the alveolar gas, which is coming from the alveoli, which contains carbon dioxide, but it also contains humidity and warmth. Now we move on to the Mapleson A circuit or Magel circuit. See, this circuit, the components. So whenever you describe a circuit, describe in terms of anatomy, that means parts, and physiology. Physiology means functional analysis. Okay. So this has got a fresh gas inlet, and there is a reservoir bag. There is a corrugated tube, and there is an APL valve, and this is the patient end. So the fresh gas enters. It can go to the patient. At the same time, it can go to the reservoir bag and filter, and it goes to the patient. And during expiration, the expired gas comes back, and at the same time, you see the gas is coming from the fresh gas inlet. So there will be some building up of pressure inside the circuit, which will open up and allows the gas to go out. Now, this is a modified version of Magel circuit. The difference you see is the scavenging system. See, here there is no scavenging system. Here there is a scavenging system. And moreover, this valve is a metal valve, which is heavy. But this particular valve is made up of plastic. It is not so heavy. And this tube is a little longer. And this is made up of black rubber, but this is made up of plastic. Now, this is how it works during the spontaneous breathing. You can see during inspiration, the gas is going in. During expiration, the gas comes out and fills the reservoir bag. And during expiratory pause, I repeat, during expiratory pause, the valve is getting open and the gas is vented out. So, expiratory pause is a very important thing. And this circuit, Mapleson A or Magel circuit, is considered as the best circuit for a spontaneously breathing patient. Now, let us go to the function analysis of the circuit. So, whenever you say function analysis, you have to say it in two headings: during spontaneous breathing, during controlled ventilation, right? And few points you have to keep in mind are, during spontaneous breathing, the APL valve is always kept open, like this. You can see in the picture on the left side, the valve is kept open. And during controlled ventilation, the valve is kept partially closed. And another important point is, fresh gas will continuously flow during inspiration, expiration, and expiratory pause. So there is no interruption of fresh gas flow, whether it is inspiration, whether it is expiration, whether it is pause, the fresh gas flow will continuously flow into the circuit. Okay, let us see what happens during spontaneous respiration with a Mapelson A system. Here you see the Mapelson system is filled with fresh gas and patient is inspiring. The gas will go and you will see the bag is collapsing. There is no confusion about it. Now we move on to the expiration. So when during expiration, what happens is you can see the expired gas which contains the dead space gas. I said there is no carbon dioxide, but it contains humidity and warmth, and also the alveolar gas which contains the carbon dioxide. So you can see the dead space gas followed by alveolar gas is coming from the patient and moving towards the reservoir bag because it's during expiration. And remember, at the same time, the fresh gas from the fresh gas inlet is moving towards patient. So you can see two flows are occurring inside the tube. The expiratory gas which contain the dead space gas and alveolar gas moves towards the reservoir bag. At the same time, the fresh gas which is continuously flowing will move towards the patient. So what will happen? There will be building up of pressure inside the system. Now we reach the expiratory pause. Now during expiratory pause, there is no flow from the patient because it is pause. So in expiratory pause, there is no respiratory movement. So the only flow happening in this circuit is the fresh gas flow. So what will happen? The fresh gas flow will push the alveolar gas and dead space gas towards the APL valve, and you can see clearly that the valve is opening because 1 centimeter water pressure is sufficient to open up the valve because you have kept the valve in an open position, isn't it? Now the alveolar gas is going out and the expired gas has gone out, which contained carbon dioxide. Now what happens during next inspiration? During next inspiration, see, most of the alveolar gas gone out. So patient will be inspiring the dead space gas and the fresh gas. So for this to happen, you have to provide a fresh gas of around minute ventilation. 1 minute ventilation is what you need. And if you want to allow some rebreathing, because I said rebreathing is not always injurious, deleterious, because when you rebreathe dead space, there is no problem. When you rebreathe carbon alveolar gas, it contains humidity, it contains warmth, it contains carbon dioxide. So a minimal rebreathing will not do much harm to the patient. In such a situation, you can use 70% of minute ventilation. But remember, the ideal fresh gas flow when you use Mapelson A for spontaneous breathing is minute ventilation. Now, instead of spontaneous breathing, you are going to control the ventilation with a Mapelson system. What is going to happen? Look at this picture. See, this system is filled with the fresh gas and you are squeezing the bag. And when you squeeze the bag, look at the APL valve. Because here the APL valve is partially closed. It is not open as in the case of spontaneous breathing. It is partially closed, so you need a higher pressure to open it up. So when you squeeze the bag, a higher pressure is developed and you can see the fresh gas is escaping to the atmosphere and also going towards the patient. There's no confusion about that, right? Now we move on to the next phase, expiration. What happens during expiration? See, during expiration, as in the previous case, you can see the dead space gas followed by alveolar gas is entering the circuit. And here you see that they have moved much more distance than that in the spontaneous breathing status because the amount of fresh gas here is less than that in spontaneous breathing status because during the squeezing of the bag, you have expelled some amount of fresh gas also into the atmosphere. So that is the reason for the more movement of this alveolar gas and dead space gas towards the reservoir bag. And during expiratory pause, what happens is this movement has stopped. This Backward movement has stopped, but the fresh gas flow is still going and filling. Now you can see in the reservoir bag, there is a mixture. You see fresh gas, you see dead space gas, and here you see alveolar gas also. Okay. Now this is the expiratory pause. There is no movement from the patient side, but the fresh gas is filling. You can see the bag is filling up. Now what's the next phase? What's the next phase? Next phase is inspiration. So during the next phase, you will see that gas in this area, which was predominantly alveolar gas, is pushed outside. But look at the picture carefully. The alveolar gas is pushed outside. At the same time, the alveolar gas is inhaled also. Now following the alveolar gas, the dead space gas and fresh gas is also escaping, and the same gas will also enter the patient. So that means the amount of alveolar gas containing carbon dioxide is much more than that compared with a spontaneously breathing patient. So fresh gas flow requirement during spontaneous breathing, during controlled ventilation is 3 times the minute ventilation. During spontaneous, it was only minute ventilation, but when you use Mapleson system A for controlled ventilation, the minute ventilation increases to 3 times. Now we move on to Mapleson B and Mapleson C. See, Mapleson B, what you see here is that fresh gas flow has been shifted from near the machine towards the patient. See, in Mapleson A, this fresh gas flow somewhere here, but here it just moves towards the patient just behind the APL valve. Okay, and otherwise the anatomy is same as that of a Mapleson A system. Here, the expiratory valve will open when the pressure in the circuit increases, and what happens is a mixture of fresh gas and alveolar gas is going to escape. You know why? Because fresh gas is here, APL valve is here. So there is always a mixing up of alveolar gas coming from the patient and the fresh gas coming from the machine. So mixing up of both will happen, and that will be expelled through the expiratory valve. So fresh gas flow requirement is around twice minute ventilation. It is applicable for both spontaneous and controlled ventilation. There is no difference in fresh gas flow, and nowadays, Mapleson B is an obsolete circuit. Nobody is using it. Now we move on to Mapleson C. In what way this is different from Mapleson B? Just compare. See, there is a rebreathing tube or a breathing tube in the Mapleson B, which is absent in Mapleson C. So that is the only difference between Mapleson C and Mapleson B. And Mapleson C is also known as water circuit without an absorber. I hope all of you remember the water circuit, which is a to and fro circuit with carbon dioxide absorption. And when you remove this the absorbent or the circle absorber, it will become Mapleson C. And fresh gas flow, as in the case of Mapleson B, it is twice minute ventilation for both spontaneous breathing and for controlled ventilation. So far we have discussed about Mapleson A, B, and C. Let us just compare and contrast. I said always think in terms of anatomy and physiology. Okay, let us consider the anatomy. Of course, in all circuits, the APL valve is close to the patient. Okay, and in the A circuit, fresh gas flow is away, but in B and C, it is just behind the APL valve. Second difference. And considering the reservoir tube or the corrugate tube, the tubes are there for A and B, but there is no tube for Mapleson C. And regarding reservoir bag, you can see that this reservoir bag is in the afferent limb. What do you mean by afferent limb? See, afferent limb is the limb which brings fresh gas from the machine to the patient. That is upper limb. See, every circuit has an afferent limb and efferent limb. Afferent means bringing towards. Efferent means going away. So afferent limb is that limb which brings fresh gas, and efferent limb is that limb which expels the expired gas. Okay. Here what you see is the reserve bag is placed in the upper limb. Look at this picture. The fresh gas is going, upper limb. Look at this picture. Fresh gas is coming, and this is an upper limb. Look at this picture. Fresh gas is coming, and this is the upper limb. So you can see that reserve bags are placed in the afferent limb. And considering the physiology, the fresh gas flow requirement for Magill's or Mapleson A is minute ventilation for spontaneous breathing, 3 times minute ventilation for controlled ventilation, and for the other two, whether it is spontaneous or controlled, fresh gas flow requirement is twice minute ventilation. And in all these A, B, and C, the reservoir is placed in the afferent limb. Let's move on to Mapleson D. So there is a striking difference between the earlier systems and this one. Here you can see the fresh gas is close to the patient and valve is away from the patient. That's a major striking difference between the earlier circuits and this one. The fresh gas flow has come close to the patient while the valve has been moved away from the patient. So you can say that in this system, this is the upper limb. I'm just tracing it. So this is the afferent limb and this is the efferent limb. I think it is clear. So in Mapleson D, the reserve bag is placed in the efferent limb. Now I will show you a modified Mapleson D. I said this modification was done by Bain and Sporrell. Here, look at this fresh gas tube. Instead of joining from outside, the tube enters into the circuit and move inside and finally reach near the patient end. The fresh gas moves in towards patient while the expired gas moves in the opposite direction in the outer tube. That means these two flows are in the opposite direction but in the same axis. So you can call this modified version as a coaxial circuit. So you can call Bain circuit as a coaxial version of Mapleson D. What's the advantage of making them coaxial? It's very simple. You can see in the picture, fresh gas is moving towards a patient which is dry, which is cool, which is not humid, and the expired air which is moving in the opposite direction is humid and warm, and the heat, the warmth can be transferred from the expired air into the inner tube. But remember, humidity cannot be transferred. Only warmth will be transferred across that plastic tubing. Now, when you consider the Bain circuit, I said it was introduced by Bain and Sporrell in 1972. Let us consider its anatomy. There is an inner tube. You can see there is an outer tube. The inner tube has a diameter of 7 millimeters. Outer tube has a diameter of 22 millimeters, and the length of the circuit comes to about 180 centimeters. You can see the inner tube is extended out, and this is connected to the machine. There is an APL valve, which is not heavy, and there is a reserve valve also. Now I will show you a modified Bain circuit. What difference do you notice between these two? In the first one, the fresh gas attachment to the machine is far away from the circuit. There's a long tube between the connection and the circuit. But here, the circuit itself is mounted onto the anesthesia machine. So actually that is a disadvantage, because with this particular circuit, you can move around. But here, since the reserve bag is near the workstation, near the machine, You cannot move around, but there is a definite advantage. Look at that valve. The valve has a scavenging attachment. So scavenging of expired gas is possible with this modified version, while that is not possible with the older version. So the advantage of this particular is that the scavenging is made easier. Now this is how the physiology of this circuit works. You can see during inspiration, the fresh gas flow coming through the inner tube is going towards the patient, and during expiration, the expired gas enters the outer tube and moves towards the reservoir bag and valve. And a point to be noted here is, look at this point. Here is the point where the inner tube ends, and through this tube, the fresh gas is coming out. So the expired gas is always mixing with the fresh gas coming from the inner tube and going towards the reservoir bag and valve. That's a very important point. There is always a mixing up of expired gas and the fresh gas because the tip of the inner tube is near the patient end. Now, let us see the fresh gas flow requirement for Bain circuit. The Bain circuit is best for control ventilation. It is not an ideal circuit for spontaneously breathing patient. The fresh gas flow requirement is about 70 to 100 ml per kilogram per minute. And this was the recommendation of Bain and Spurrell, but nowadays nobody is using Bain circuit for children less than 20 kg. So the take-home message is, for an adult, you can use 70 ml per kilogram per minute. The minimum flow to be used with a Bain circuit is around 3 to 3.5 liters. You should not reduce the flow less than that. And I said it is for controlled ventilation. So whenever you control the ventilation, the tidal volume should be around 10 ml and respiratory rate should be around 12 to 16. You should not increase the respiratory rate too much, because if you increase the respiratory rate too much, the expiratory pause will be shortened and there will be inadequate expulsion of the alveolar gas. So that's a very important point. Too much hyperventilation with Bains is not going to do any good for the patient. If you look at the capnogram, you will see that with your hyperventilation, the baseline is simply increasing. So the maximum rate is 12 to 16 is ideal. Never go more than that. If you want to eliminate carbon dioxide, rather than increasing the rate too much, you go on increasing the fresh gas flow to the Bain circuit. That is more effective than doing too much hyperventilation with a Bain circuit. Now, spontaneous ventilation is not recommended for a Bain circuit for a long time. But when you use Bain circuit for spontaneous ventilation, you need to use a very high gas flow of around 200 to 300 ml per kilogram per minute, which comes to about 2 to 3 times the mid ventilation. So that's a very important point when you use Bain circuit during your extubation process. Whenever you use it, always go for a higher flow. Otherwise, there will be carbon dioxide accumulation and the hypercarbia itself can lead on to delayed recovery. Now, let us go on to the function analysis. What happens when the Bain is used for spontaneous respiration? The initial picture during inspiration, see the whole system is filled with fresh gas flow. There is no confusion. So the fresh gas will go to the patient and the bag will collapse. The next phase, the expiration is happening. You can see the alveolar gas, which is following the dead space gas, is entering the outer tube. You can see the outer tube. And it is moving towards the reservoir bag. And its movement is facilitated by the fresh gas flow coming through the inner tube. I said, it never stops. It continues, whether it is in inspiration or expiration or expired pause, it continues to flow. So there is a mixing up of this alveolar gas and dead space gas with the fresh gas. And you can see they are reaching, these gases are reaching the reservoir bag, right? No confusion about that. Now we move on to the expiratory pause. See, in expiratory pause, there is no movement towards reservoir bag from the patient side. Okay, but there is an inspiratory tube which carries fresh gas, which pushes the dead space and alveolar gas further towards the reservoir bag, which will increase the pressure in the system. Valve will be opening and the gas is going out. So fresh gas will be going out, alveolar gas will be going out, dead space gas also going out. Okay. Now we will see what is going to happen during next inspiration. So next inspiration, see, some of the alveolar gas will invariably push back to the patient lung. When you squeeze the bag, the alveolar gas which is collected in the outer tube will be pushed back to the patient. So what patient inspires is a combination of fresh gas and alveolar gas. So that again depends upon the fresh gas flow rate. If the fresh gas flow rate is low, patient is going to inhale more alveolar gas, and if it is high, patient is going to inhale less alveolar gas. So I said already, fresh gas flow requirement during spontaneous breathing with a Bain circuit is around 2 to 3 times the minute ventilation. Now let us see what is going to happen during controlled ventilation. Now, the first picture, the whole system is filled with fresh gas. The anesthetist is squeezing the bag, and look at the valve. Some of the fresh gas is lost into the atmosphere, and the other part of the fresh gas is going towards the patient during inspiration. Now, the expiration has reached. Like the earlier scenario, you can see the expired gas which contains dead space and alveolar gas is going towards the outer tube, towards the reservoir bag, which is pushed further by the fresh gas coming through the inner tube. Can you see the inner tube? Can you see the fresh gas coming? Which is actually pushing these expired gases towards the reservoir bag. And during the next inspiration, what happens is this dead space gas and alveolar gas plus fresh gas collected in the reservoir bag is pushed through the valve. At the same time, some amount of alveolar gas which was inside that outer tube will be pushed back. So a very important point to be remembered is that during controlled ventilation also, some amount of alveolar gas goes back to the patient. So Mapleson D system is a system with some amount of rebreathing. I will show you the capnogram of a patient when Bain circuit is used. And during controlled ventilation, I said earlier, the fresh gas flow requirement is 70 to 100 ml per kilogram per minute. If the fresh gas flow is higher, the amount of carbon dioxide going to the patient will be less. If it is lower, the more carbon dioxide will go back to the patient. Look at this picture. So there is expiratory pause. You can see that there is a nice capnogram showing the expiratory, inspiratory upstroke, expiratory plateau, and inspiratory downstroke. I repeat. Okay, this is the inspiratory downstroke, expiratory upstroke, expiratory plateau, inspiratory downstroke. Okay, now please look at this inspiratory phase of the capnogram. This is the inspiratory phase of the capnogram, isn't it? Can you see some amount of carbon dioxide built up in the inspiratory phase? Look at here. Look at here. So this is called the signature capnogram of the Bain circuit. I said The vein circuit is a rebreathing circuit. Some amount of rebreathing will be there, and this small upstroke of this or accumulation of carbon dioxide is because of the exhale gas which you have pushed in during the inspiratory phase of the respiratory cycle. You can just compare this capnogram with a capnogram which you see with your circle system. Do you see any carbon dioxide accumulation during that inspiratory phase with a closed system? Never. So next time when you use vein circuit, please look at the entyl carbon dioxide, and you will definitely see this inspiratory building up of carbon dioxide. And if you increase the fresh gas flow, you will see that the amplitude will come down, and if you decrease the fresh gas flow, you will see that the amplitude will go up. So I repeat, whenever veins is used for controlled ventilation, use a trial volume of around 10 ml, and respiratory rate should be around 12 to 16. Too much respiratory rate is not going to do any benefit for the patient. Now, before you start the anesthesia in the morning, always test the vein circuit, because vein circuit is having multiple components. So there is a chance of error always. So testing of vein circuit is mandatory. Not only vein circuit, any circuit you have to test, but particularly important when you use a vein circuit. How to test? It's a usual question in the exam. One is simple inspection. You look at the inner tube through the outer tube, see whether any breaks are there, see whether any kinking is there. You can see the outer tube. And this particular point is very important. This is the point where the inner tube is joining with the continuation of the tube towards the machine. So in many of the newer vein circuit, the whole tube is a single one. But in some of the older vein circuit, there was a junction. This is a separate tube and the other one is a separate tube. So there could be chances of disconnections which can be fatal. So always check that junction is intact. You look at the outer tube for any holes or any damage. You look at the extension of that inner tube for any kinking or any damage. You look at the AP valve. You check that AP valve that is moving freely or not. And you look at the reservoir bag. This is simple inspection. Now next is, you are going to check there is any leak in the system. That is, you want to check the integrity of the outer tube, reservoir bag, and APL valve. This test is very simple. You occlude the patient end, close the APL valve, and fill the reservoir bag with oxygen flush, and see whether it is deflating by itself. If it is deflating by itself, that means there is some leak. And you can pressurize the system also. Next is the tests for test for knowing the integrity of the inner tube. Now there are three tests. One is Pathex test, second one is the inner tube occlusion test, and third is the double tube occlusion test. Let us move on to inner tube occlusion test. So here you set a very low flow on the oxygen flow meter, 0.5 or 1 liter. Second step is occlude the inner tube with a finger, or better you use a 2 ml syringe. The barrel of the 2 ml syringe is better than using your finger at the patient end. The third step is you observe the flow meter indicator, and if there is no leak in the inner tube, the indicator will dip, and you can say that inner tube is intact. This is called inner tube occlusion test. Now we move to Pathex test, a very commonly asked question during Viva. Listen carefully the different steps. Fill the bag after occluding the patient end. You can use the oxygen flush for filling. You see the bag is filled. Now you activate the oxygen flush. At the same time, you relieve the occlusion of the patient end. You remove the hand and activate the oxygen flush and see the bag. What is going to happen to the bag? So bag will deflate if the inner tube is intact. What is the mechanism by which the bag is deflating? See, this is because of the Venturi effect. The high flow from the inner tube at the patient end will create a negativity at that area. And when there is a negative pressure is developing, that will suck the gas from the bag and bag will deflate. Suppose you see that the bag is inflating slightly, that means your inner tube is not intact. There is some problem with your circuit. Look at the picture on the left side. The inner tube is intact. You can see the Venturi effect caused the negative pressure, and because of the negative pressure here, the gas is sucked from the reserve bag and the bag has collapsed. Look at the picture on the right side. There is an inner tube damage. See, there is a crack in the inner tube, and when you activated the flush, the fresh gas, instead of going through the inner tube, it entered the reserve bag and caused the inflation. Now before going to advantage, what is double occlusion test? Now here you occlude both inner tube and outer tube. It is a difficult task, and you just activate the oxygen flush. So when the inner tube is activated, no gas should enter the outer tube, isn't it? And if the reserve bag is inflating, that means there is some problem with the inner tube. That is a double occlusion test. Now, what are the advantages of bench circuit? It is lightweight, so you can move around. With Magel circuit, the ALP valve is heavier, but with Baines, it is light, and resistance is very low. And since the outer tube is transparent, you can see the inner tube clearly. And it is easy to move between controlled ventilation and spontaneous ventilation. And it is a very useful circuit in MRI suits. And moreover, the exhaled gases are not accumulating near the patient end, as in the case of a Magel circuit. So there is no problem of airway fires. And if you use a modified version of Baines circuit, you can scavenge the gases from the theater. And it is easy to connect to a ventilator also. You just remove the reserve bag and connect the tubing towards the ventilator. And since some rebreathing is allowed, I said in the ETCO2 you have seen there is a carbon dioxide peak during that inspiratory phase. That rebreathing will provide some amount of the humidity and warmth. Now, what are the disadvantages? See, there are multiple connections. So there is a risk of disconnection. Second point, wrong assembly can lead on to malfunction and can be fatal. So in the exam, you will be given a dismantled Baines circuit and you will be asked to put into the right shape. So you should not fail in that process. You should know how to assemble the Baines circuit in a proper way. And theater pollution occurs because you are using very high flows. You can use a scavenging system, but by using scavenging system, you are avoiding theater pollution, but you are not avoiding atmospheric air pollution outside the OT. And of course, cost is going to be high whenever you use high gas flows. And if the inner tube is kinked, no gas will reach the patient and can put the patient into risk of hypoxia. And a crack in the inner tube can cause leakage and can extend the dead space and can cause dangerous hypercarbia. And it cannot be used in children below 20 kg. Now we move on to Mapelson E circuit, which is the modification of ISTPs. I said ISTPs was invented in 1937. This is the original ISTPs. You can see it was invented in 1937. It is a metal tube. The diameter is about 1 centimeter and its length is about 5 centimeters. And there is a side port you can see through which fresh gas is entering. And through one limb, gas goes towards the patient, and through the other limb, gas will be going out. You can call this limb as expirator limb and this limb is inspiratory limb. And this is the modification of IST. What modification you find here? In the original IST piece, there was no expiratory limb. This reservoir 2 was lacking in the original IST piece, which is added in Mapelson E. And what's the function of this reservoir tube? Suppose there is no reservoir tube and suppose there is no expiratory limb. What will happen? During spontaneous breathing, the air can go into the patient's lung and can cause air dilution. So that can result in dilution of the anesthetic gases. So to prevent that air dilution, an expiratory limb is added. And there is one classification also for ISTPs without any expiratory limb, with an expiratory limb whose volume is less than tidal volume. And the third one is with an expiratory limb whose volume is greater than the tidal. This is the class, this is called Harrison's classification. And the advantage of Mapelson is that its dead space is minimum. There is no valve. So it is a valveless circuit. Since there are no valves, the resistance is minimum. So very ideal circuit for infants, neonates. And I said earlier, air dilution can be prevented by keeping the volume of expiratory limb. This is the expiratory limb greater than the patient's tidal volume. And this is how it functions. You can say the fresh gas is continuously reaching the patient end, and during the inspiration, patient draws in the fresh gas as well gas in the reservoir tube, and during expiration, the expired gas is pushed out by the fresh gas coming from the fresh gas inlet. And the fresh gas flow requirement is for spontaneous breathing, it is 2.5 to 3 times minute ventilation. And for controlled ventilation, it is around 1.5 to 2 times minute ventilation. That means still the fresh gas flow requirement is high. Now we move on to Mapelson F's circuit, which is actually called as Jackson-Rees modification of ISTPs. This circuit was introduced by Jackson-Rees and included in Mapelson classification later date by Willis et al. The advantage of Jackson-Rees modification over ISTPs is that there is a reservoir bag. You can see the reservoir bag with a tail which is having a hole. So because of the reservoir bag, you can see the respiratory movements and also you can control the ventilation. With ISTPs, controlled ventilation was done with your thumb. You call it as thumb ventilation. You have to intermittently occlude the expiratory limb, which will facilitate the inspiration. Okay. Of course, there is a danger of barotrauma. If you keep the expiratory limb closed for a longer time, there's a chance of alveolar rupture and pneumothorax. But here, that problem is not there because there's a reservoir bag which will buffer the airway pressures inside the circuit. And fresh gas flow requirements are similar to that of an ISTPs. With spontaneous breathing, it is about 2.5 to 3, and with controlled ventilation, it is 1.5 to 2 times. See, this is a modern ISTPs. You see here, this TPs is metal in the older version, but here it is plastic. And the fresh gas inlet is longer, and the expiratory limb is also a little longer with a reservoir bag with a hole in the tail. What's the function of the hole in the tail? It is acting like the expiratory valve. So during spontaneous breathing, you just keep that tail open, but during controlled ventilation, with the thumb, you have to occlude that tail partially to facilitate, the inspiration. And in some Jackson-Rees circuits, there is something called a back tail valve. You can turn the valve to change the resistance. And this is another reservoir bag used in Jackson-Rees having a side hole, which is known as Kuhn bag. Now, LAC circuit. Actually, this circuit was introduced in 1976. by Dr. A. Lack. This is a modification of Mapleson A circuit. And this is a coaxial version. So these are the two differences. One is it is a coaxial version. Second one is it will facilitate scavenging of expired gas. With the original Mapleson A, there was no facility for scavenging, but here there is a facility for scavenging. Look at this picture. This is a coaxial circuit. There is an inner tube, there is an outer tube. But unlike the Bain circuit, the inner tube is carrying the expired gas from the patient. You can see it is carrying expired gas towards the valve. Look at this picture. Expired gas is inside the inner tube, which is going out through the APL valve. And the outer tube, unlike the Bain circuit, here the outer tube carries the fresh gas towards the patient. See, expired gas is moving through the inner tube and going out, while the outer tube is carrying the fresh gas. And in the case of Bain's, the opposite thing. Inner tube is carrying the fresh gas and outer tube is carrying the expired gas. This is another modification of Lack system. Instead of coaxial, there are two parallel tubes. So this is called as a parallel Lack system. Now, this slide shows you the Mapleson A, B, C on the left side and Mapleson D, E, F on the right side. I would like to put a line between them. You know why? Look at the reservoir bags on the left side. So for the A, B, and C, the reservoir bag is seen in the afferent length. So I would like to classify them as afferent reservoir system. Look at the circuits on the right side, D, E, and F. There, the reservoir bags or reservoir is seen in the efferent limb system. That means the limb carrying the expired gas. So I would classify them under efferent reservoir system. So ABC, afferent reservoir system, DEF, efferent reservoir system. Now, something about reservoir bag, because it's a very important component of the anesthesia circuit. You know the function of reservoir bag. It is known as breathing bag also because it provides the peak inspiratory flow rate, PIFR, and thus acting as a reservoir of anesthetic gases. That's the first function. Second, you can have visual and tactile perception of the respiratory movement. And you can squeeze the bag and provide positive pressure ventilation. And there is one more important function for the reservoir bag, that is, it is a compliant bag. It is working as a buffer in the anesthesia breathing system. How? See, once the normal capacity, let's say 3 liters is achieved, the pressure in the system will increase to a peak. Okay? A peak pressure is achieved. And even if you increase the volume further, surprisingly, there is no increase in the pressure because the bag is compliant. Still, you are increasing the volume. What will happen? The bag will burst. So, the reservoir bag is protecting against building up of high pressures in the anesthesia circuit. So, you can call the reservoir bag as a buffer in the anesthesia circuit. Look at this picture. These are the reservoir bags inflated to various volume. In the bottom, you can see the pressure volume graph. In the horizontal axis, there is volume. In the vertical axis, there is pressure. Now I am going to inflate the bag to its maximum capacity, and you can see there is a sudden increase in the pressure. Now I am going to increase it further. Actually, you see a slight dip, and it usually remains at a value of about 50 to 60 centimeters water. See, I am increasing the volume further. You see, there is no increase in volume, and now I am increasing the volume too much, and what happens is this reservoir bag is bursting, and my patient's airway is protected against high pressures. Now, regarding apparatus dead space, this is a usual question in Viva. You will be asked to show the apparatus dead space. Now, what is apparatus dead space? See, this is the fresh gas flow going into the patient, right? Look carefully, the fresh gas is going towards the patient, the green one. Now, I am going to draw the expired gas going from the patient, the yellow line. Okay, inspired gas going in, expired going out. And there is a particular point at which these flows are crossing. The inspired flow and expired flow, they are crossing at a particular point. Okay. Now, from that point towards the patient is the dead space. This is how you find out the dead space. The point where inspiratory flow is crossing the expiratory flow. From that point towards the patient is the dead space. Okay, I'm going to mark dead spaces in all these circuits. This is a dead space. Once you remove the mask, dead space is reduced. In the B and C, these are the dead spaces. And in the D, this is a dead space. You can see the inspired gas is coming in and expired gas is going out. That junction towards patient is a dead space. And what about vein circuit? In the vein circuit, the point where the inspiratory limb ends, from that point towards the patient is a dead space in a vein circuit. Similarly, in E and F, you can mark the dead spaces. Now, this is the last slide. Now, instead of telling the summary, I thought of giving you some questions for brainstorming for the PGs, of course. My first question: best anesthesia circuit for spontaneously breathing adult patient is? The answer is Magill circuit or Mapleson A circuit. Anesthesia circuit used for weaning a patient from mechanical ventilation is? It is the TPs. Anesthesia circuit having similarity with an ambu bag is? It is Mapleson C circuit. And anesthesia circuit which is valveless, answer is TPs, ISTPs. Fresh gas flow for vein circuit during spontaneous breathing is 2 to 3 times the minute ventilation. Mapleson circuit which was added latest is the Mapleson F circuit. And the coaxial version of Mapleson A is called the lax circuit. Now, these are the 7 fill up the blanks. Now, the 3 questions remaining are true or false. You have to find whether the statement is true or false. Mapleson circuits offer less resistance than circle system. See, when you look at the circle system, you can see 3 valves, 2 unidirectional valves and 1 APL valve. How many valves you see in a Mapleson circuit? Only an APL valve. So, this statement is true. Even if there is a hole in the reservoir bag of a Magill circuit, dead space remains the same. See, consider a hole in the reservoir bag. Now, the APL valve has become non-functional because whenever the pressure in the circuit increases, the expired gas, instead of going through the APL valve, will be going through the hole in the reservoir bag. See how much increase has happened to the dead space. The dead space has extended from the patient towards the reservoir bag, including the breathing tube. So, a dangerous increase in the dead space has happened. So this statement is false. There will be a definite increase in the dead space when there is a hole in the reservoir bag in a Bagel circuit. The last question, thumb ventilation with TPs is always guided by chest expansion. True or false? So whenever you are using your thumb to occlude the expirator limb of an ISTP, look at the chest. Look for a visible chest lift. Once you attain the visible chest lift, which indicates about 8 ml per kilogram trial volume, you release your finger to allow for the expiration. If you keep the expirator limb occluded, what is going to happen? There is barotrauma. So the end point of exclusion of expirator limb is the visual assessment of chest expansion. That means whenever you do thumb ventilation, please look at the patient's chest instead of looking somewhere. Okay. Now, I express my gratitude to ISA Kerala for giving me this opportunity. Thank you very much and stay safe.
Thank you, Dr. Baburaj, for the excellent session. I think Dr. Baburaj will take the questions at the end of the next session. So we'll go to the next session. The next session is the second part of drugs in anesthesia. The first part was well received by the postgraduate students, and there was a request for the postgraduate students to have the second session immediately in view of their practical exams, upcoming practical exams. So we have the internal examiner as none other than our own state president, active state president, Dr. Abdul Nasser, who is a senior consultant from Skills Al-Shifa Perindalmanna, and was my senior in the Calicut Medical College during my MBBS days. And we have an external examiner, Dr. Sanish PJ, who is a senior consultant at Anandaburi Hospital and a faculty for DNB studies. And he has authored a textbook also and is an active member in the Indian College of Anesthesia as a faculty member. And he was formerly associated with the KMC Manipal. And we have two postgraduate students, Dr. Fayaz Hamzat and Dr. Fatimat Sara. Over to Dr. Sanish PJ and Dr. Abdul Nasser.
Yes, good evening all. We have two PG residents from KIMS Al-Shifa Hospital, Perindalmanna, Dr. Fiyaz Hamzat and Dr. Fatimat Sana. And Dr. Sanish PJ will be presenting the topic. I came to know that he has made this pharmacological topic in an excellent and interesting way, so that it becomes very pleasant for PCs to hear it. So Dr. Sanish, please start your presentation.
Thank you very much, sir. At the outset, let me thank the Kerala ISA PG Update Scientific Committee and Kerala ISA office bearers, Dr. Nasser, Dr. Benil, and Dr. Venkatagiri for giving me this opportunity, especially to continue with our module 1 of drugs Viva stations. Today, I have planned to discuss IV anesthetic agents, which will include benzodiazepines as well. I request my PG delegates to introduce themselves before we start.
Hello?
Yeah. Please go
I'm
ahead.
Dr. Fiyaz.
Okay.
I'm a final year DNB resident at KIMS Al-Shifa Hospital, Perindalmanna.
Okay, Dr. Sana.
Hello, myself Dr. Sana, Dr. Fatimat Sana, second year DNB resident from KIMS Al-Shifa, Perindalmanna.
Okay. Today, actually, I have designed in such a way that most of the people in the audience can also participate in our discussion. It's going to be an interactive session. It will not go in a single line format. I think one of the feedback we got from the last session was somebody was telling if there are question answers, it's only for postgraduates, but I believe we are all students till our last day in the specialty. And thing I would like to mention is, since I started preparing for this session, I came to learn a lot, and I think the learning continues. And since I see many of my teachers, seniors among the audience, you're all free to correct me, because reading this sentence again and again with experience, with knowledge, also brings up new meaning. So in case if there is any misinterpretation of fact, please feel free to correct me. We'll proceed in a format like we'll have some case scenarios where the candidate will be asked to pick up their induction agent of choice, and then we'll go ahead discussing about that drug, like in a Viva station. Of course, there will be sideline questions like comparisons and all. I've already mentioned how to prepare for a drugs Viva station. You need to have at least 5 to 6 strong drugs where you are confident that you can get almost 80% of the questions on basics correctly. Forget about the updates and recent advances. If you answer well, you'll get better rating. That's all. It will not make you fail. Okay, also I would like to involve all the audience. There are some audience poll questions also waiting for you. Okay, there are some audience poll questions waiting. So we'll take it one by one. So for starting, I'll request Dr. Fayaz to take the first case scenario. It goes like this. A patient with intestinal obstruction requires emergency laparotomy. Which induction drug would you use?
Intestinal obstruction means this patient would need a rapid sequence induction.
Yes.
I would use propofol.
Yeah. Why do you choose propofol?
Propofol has a very rapid onset of action.
Okay.
Only one brain arm circulation time will be required for its induction.
Okay.
So I would choose, it is the most commonly used induction agent. And also I am familiar with propofol because of using it regularly. So I'll use propofol as my induction agent.
Okay, fine. So what all preparations you know of regarding propofol?
There are numerous preparations available for propofol.
No, what
most
all
commonly,
things you have used so far?
I've used only propofol with 1% propofol, which is 10 mg per ml. Okay. It is preservative free, so we'll have to have a very aseptic precautions has to be used before using this preservative free propofol, because it can cause it has very high chance of bacterial contamination, and also have to be discarded within
preservative factor or the co-contents of the preparation.
Also co-contents of the preparation. It has 10% of soybean oil, 1.2% of egg phospholipid, purified egg phospholipid. Some preparations have methyl bisulfate and EDT as the preservative.
Okay. Okay, fine. It belongs to alkyl phenols. Okay, it has got 2.25% glycerol as tonicity adjusting agent also. The pH of this propofol is
7.1.
Yeah, around 7. And can you name any other drug which looks like milky white?
Etomidate.
Yeah, sure. Okay, that's fine. So can you tell us about the clinical uses of propofol?
Propofol is most commonly used as an induction agent.
Okay.
It has a very rapid and short duration of action because its metabolites are mostly inactive.
Okay.
It has a one brain arm circulation time for its induction. The peak action is within 90 to 100 seconds. Okay. So it is most commonly used as an induction agent.
Okay.
Also,
what dose you will be using?
Sir?
What dose? How much
I'll be using it 1.5 to 2 mg per kg. As
okay.
1.5 to 2.5 mg per kg can be used as an induction agent.
What are the routes of administration?
It is used only as an IV agent, intravenous agent.
Any other use?
It can be used as an antiemetic. It is used as because of its action in the area posterior in the central nervous system. It can cause 5-HT3 antagonism and has antiemetic action. It is also used for opioid-induced pruritus. It is used as a treatment of pruritus. It can be used as a sedative agent in ICU.
Okay, it can be used for the maintenance of general anesthesia also. So whenever you mention a use, mention the dose also, how you are planning to use. Okay, the dose is given in the slide for verification. These slides are basically for the audience for clarity, so there should not be any communication issue. Fine. So what are the effects of propofol on various systems?
I'll start with central nervous system.
Okay.
It's an sedative hypnotic. It has a GABAergic agonism.
Okay.
It causes increases the chloride conductance, and as a result, it has a very fast onset of a loss of consciousness. Loss of consciousness, the exact mechanism is not fully understood, but most commonly it is because of the action of the hippocampus, but it causes decreased acetylcholine release. That is the main reason behind the loss of consciousness. It has the cerebral blood flow. It reduces the cerebral blood flow. But in case of traumatic brain injury, it can also reduce preferably reduce cerebral perfusion pressure, along with reducing the IGP. So it may not be a good agent for induction in case of increased IGP. That is the main CNS effect. Like I already mentioned, can be used as also as a maintenance agent during anesthesia. It also has anti-emetic effect because of the action in the area postrema. The patient can have a pleasant feeling after coming out of propofol because it has a dopamine agonism in the nucleus ambiguous. These are the main CNS effects. Going into the cardiovascular system. Cardiovascular system, it reduces the it is a vasodilator, mainly by a vasodilator. Vasodilator actually is because of many mechanism of action. It increases the production of nitric oxide, reduces the production of prostacyclin. It has decreases sympathetic activity. It also has intracellular calcium modulation, and all of this can have a vasodilatory action, which results in reduction in the afterload. That is, there is a reduction in systolic blood pressure. It also has a myocardial depressant effect. It has a heart rate response is heart rate is not much changed during propofol induction because the baroreceptor action of tachycardic response is reduced by propofol. It is blunted by propofol. This is the main cardiovascular system action. It can have a because of the reduction in the blood pressure, it can reduce the hepatic blood flow. As a result, when there is a decrease in the hepatic blood flow, the clearance of the drug is reduced, and as a result, the drug concentrations in the blood, the propofol concentration of the blood will be increased after induction. In the respiratory system, it can cause apnea. Mostly, the apnea can last for about 30 seconds. But if you have given a opioid or a midazolam pre-medication, this patient can have apnea lasting for more than 30 seconds. It can reduce minute ventilation and tidal volume, and also respiratory rate can be reduced. Other systems.
It can cause bronchodilation also.
It is also has a bronchodilatory action because of there is decreased vagal tone, and methacholine also attenuation is there. As a result, there is a bronchodilation. But if there is a metabisulfate preservative present in the blood, in the solution or in the preparation, this bronchodilatory action can be blunted. This propofol may not be having this bronchodilatory action, and it also has attenuates. It also has a hypoxic pulmonary vasoconstriction effect is there for propofol.
Okay, coming to hepatic and renal for completion's sake.
Hepatic, like I said,
yeah, go ahead.
Hepatic, like I said, it can have a reduce the hepatic blood flow. It does not have any particular enzyme induction, but prolonged infusion can cause as a propofol infusion syndrome, which can lead to rhabdomyolysis and renal failure. And the renal
excretion of green urine because of phenol excretion is possible, and uric acid excretion is also increased. What are the miscellaneous actions? Generally, we speak on propofol. Already mentioned
pruritus,
action. Yes.
Pruritus, antiemetic action.
Mm-hmm.
Can cause opisthotonus, can cause
myoclonus.
hallucinations.
Okay.
Patient can have a pain on injection because of various reasons. The exact mechanism is not known. There is a very high risk of infection. Like I said, we have to be very careful while loading and have to discard the drug if it is being loaded for more than 6 hours. There is bacterial contamination chances are very high.
Okay, speaking on pain of injection, can you mention a few more drugs which can cause pain on IV injection?
Tomidate can cause pain on injection, and a very hyperosmolar solutions like potassium chloride,
yes,
thiopentone, I'm not sure.
Thiopentone may not be if you are using 2.5%. Okay, rocuronium can cause pain on injection.
Pain on injection.
Okay, fine. So we are moving ahead. What are the special other preparations of propofol you were about to tell? Because we are not happy with the 1% preparation every time. There are other preparations, may not be available in India right now.
Propofol?
Yes, that's a prodrug. Yes.
Propofol is a water-soluble prodrug that was developed, and recently in 2008 it was FDA approved. It is water-soluble, and it undergoes hepatic metabolism and produce propofol. 1 millimole of propofol can give 1 millimole of propofol.
Okay, other preparations. There is 2% preparation also available. Propofol Lipuro is available. It's containing long and medium chain triglycerides. Cleofol is called as vegetarian formulation of propofol, marketed by Themis Medicare. Okay, sometimes examiners might quiz you on these things. And non-lipid formulations, especially when you are speaking about change in the solubilizing agents like cyclodextrins, like captisol, and polysorbate 80 as solubilizing agents. We can have non-lipid formulations. Then to reduce the risk of hypertriglyceridemia, principle of more drug, less fat preparations. Like one example is soya content, oil content reduced to 5% instead of 10% in the regular preparations like ampofol, and maybe increasing the concentration of propofol from 10 to 60 milligrams per ml. These are the trials going on regarding different kind of propofol. This is an exhaustive list from one of the review articles. Okay. The handout of this presentation will be made available with Dr. Benil in a day or two. Okay, so any special concerns while using propofol? You said the possibility of infection because the preparation itself is a good culture medium.
Yes, it's an intralipid is a very good culture medium for bacterial contamination. And another concern is not in the anesthesia concern, mostly in the ICU setup, with patients with very high dose of patients like sepsis, septic patients, head injury patients, trauma patients, etc., needing prolonged sympathomimetic administration, will need if propofol is used as an sedative agent in the ICU, which will need very high doses. And that doses more than 4 to 5 mg per kg per hour will lead to propofol infusion syndrome. And propofol infusion syndrome, the patient can have rhabdomyolysis, can have cardiac issues leading to Brugada type ECG changes, bradycardia, AF, SVT, bundle branch block, etc. There can be lipemia and rhabdomyolysis, which will need renal replacement therapy. And this patient has to be closely monitored for creatine kinase, and any values more than 10,000 units per ml may require. We have to use alternative. Try to use alternative for sedation.
Okay. Plus, you need to change the full infusion dose after 24 hours or 12 hours to reduce the risk of infection developing. And regarding pain on injection, can you comment more on it?
Pain on injection
is not mentioned.
Exact mechanism is not known, but it is, some kinin-mediated mechanisms have been postulated. To reduce this, we can try to use a very large weight, avoid dorsum of the hand, and we can have pre-medicate these patients with the lignocaine, opioids, midazolam, beta blockers, etc. have been used, and ketamine can be used. These things, when you try to inject at a very fast, in a very fastly running IV fluid, and a very rapid injection. A slow injection will result in increase the chance of pain on injection. Other one, we can actually mix lignocaine with propofol, or you can also either you can give it before the injection of propofol. Both has been found effective.
Because of the high lipid content, there is a risk of hypertriglyceridemia and maybe development of
patient can go into pancreatitis.
Yes. So these are the special concerns with regard to propofol. A few more regular questions. Name the drugs causing pain on IV injection. I already asked. Why is propofol associated with a better clear-headed recovery compared to thiopentone? I think I've already mentioned all the metabolites are non-active. So can you compare the analgesic properties of IV induction agents with regard to analgesia? IV induction agents.
Every agent.
Yeah.
Yeah, analgesic property, the propofol, etomidate does not have, thiopentone does not have any analgesic property. Ketamine and dexamethasone may have some analgesic property.
No, thiopentone is anti-analgesic. Actually, that reduces the threshold for pain. Etomidate and benzodiazepines, no analgesia. They lack analgesic property. Propofol is mentioned to have mild analgesia, and ketamine gives intense analgesia. That itself is an excellent analgesic. So this is the gradation: anti-analgesic to no analgesia to mild analgesia to, when it comes to ketamine, there is intense analgesia. Okay, fine. So we'll wind up with propofol for the time being. I'll ask Dr. Sana to take the second case. Yeah, a patient with a history of throat cancer has signs of respiratory distress and marked stridor, requires tracheostomy. Which IV induction drug would you use?
I would go with ketamine this time because it preserves the upper respiratory airway reflexes.
Okay, I'll give you one more chance. So given the picture of this laryngoscopy picture of the glottis, would you still like to go with IV induction, or can you plan something else?
So, hello.
Given the picture of the patient's larynx like this, a growth obstructing the larynx, would you like to go with an IV agent, or you can have some other plans? Is there a better option than going with IV induction agents? I think our audience, you can also start putting your answers on the chat. I look for that. Any other option rather than going for my question is actually which IV induction drug would you use? But I'm modifying it. Do you have any better option? Okay, chat, you can put the answers. Okay, let's get moving. I think inhalational induction will be a better choice because you will have a better control on the depth, and in case you are unable to tackle the airway, you can come out fast, or try with minimal IV sedation, try to secure airway and then go ahead with an IV induction because the larynx is almost totally obscured. Okay, So we'll go to the case number 3. Dr. Sana, a patient requires
Okay, sir.
burns dressing change. Which induction drug would you use?
So I will go with ketamine.
Okay, here your answer clicks. Why do you want to use ketamine?
Hello.
Hello, yeah, go ahead. Why do you want to use ketamine? Hello, am I audible? Hello?
Hello.
Yeah, go ahead. Why do you want to use ketamine? Justify your choice of ketamine.
Sana, can you hear us? Hello.
Hello, Dr. Sana? Is there any audio problem?
We'll move to the next part and come back after that.
Okay, fine. So I'll keep it for later.
Yes.
So I'll go to the next case scenario. Scenario number 4. A patient with a history of heart failure requires general anesthetic. Which induction drug would you choose? Dr. Faiz.
I would use etomidate.
Okay.
Etomidate is the
What
most
specialty do you see in etomidate?
Etomidate is one of the most, it is the most cardiostable drug. So in case of any hemodynamic patients having a cardiac issue, like a valvular heart disease or ischemic heart disease, heart failure, it's always better to use etomidate because it does not cause any hemodynamic perturbation after injection. It also has a very fast onset and very rapid recovery. That is another advantage of using etomidate.
Okay, go ahead describing the chemical preparation.
Etomidate is an imidazole derivative. It is available in 0.2% solution. It's a pK value of 4.2 to 4.5. It is a weekly basic preparation, and since the pK value is 4.2, it can have it's highly lipophilic drug. The unionized form is more than the ionized form. As a result, it's very lipophilic. It's prepared with propylene glycol 35% because to have a better solubility on injection, on IV injection, we need a better solubility. For that, we are using it in propylene glycol. It is used as a solvent.
I think the preparation, what is available with us is this one, 20 milligram per 10 ml. Okay, so what is the dose you are planning to use?
I'll use mostly use 0.4, 0.5, 0.2 to 0.6 mg per kg can be used.
Okay, so on average 0.3 milligrams per kg.
Yes.
Okay, any other use for etomidate?
Etomidate can be used for a hypercortisolemia. It has been found to be useful as a treatment for
major disadvantage with etomidate.
Reduces
that is discouraging the etomidate enthusiast. It's the problem with the adrenocortical suppression. So it can be used in hypercholesterolemia also. Can you describe the effects on various systems, etomidate?
First, CNS, central nervous system, mainly it is GABAergic. It causes loss of consciousness. It is also found to be useful in the neurosurgery because it can preserve the cerebral perfusion pressure while decreasing the intracranial pressure in case of any traumatic brain injury or cases in which there is a increased ICP. So it maintains the cerebral blood flow, it reduces the ICP and maintains the CPP compared to propofol, which can have an effect on, like, it can reduce the CPP. Compared to that, etomidate is a better agent. It also has these values are very useful in monitoring the depth of anesthesia after etomidate injection. Those are the like TDF will be reduced as a result. CMR may be also reduced. But the effect on the seizures is controversial. It has been found to be useful in treatment of status epilepticus, but also has been found to cause grand mal seizures. But in case of some seizure surgeries, it can be used as an agent because it preserves the seizure potential.
Okay. Cardiovascular system. You mentioned about the
Cardiovascular system
stability.
is the most it is the most stable agent because it does not have any effect on the sympathetic nervous system, and it also does not have any effect on the barrow reflex. As a result, the BP heart rate and all are almost well maintained throughout the induction, but can cause a slight decrease in SCR. So we have to be careful while using etomidate in hypovolemic patients, because in hypovolemia, this patient can go into hypotension. It does not have any effect on the myocardial contractility. It maintains the myocardial contractility, and heart rate also is maintained after induction. This is the most cardiostable drug which can be used in case of any heart disease patient.
Okay, it's been proven useful in high-risk patients like patients with valvular or ischemic heart disease undergoing non-cardiac surgery, and especially in patients with poor cardiac function.
Since it does not have any analgesic property, this intubation response cannot be blunt. So we have to pre-treat these patients with other agents like opioids has to be given, because otherwise this patient can have very high increase in heart rate and BP while intubation. So we have to blunt the intubation response with other when we are using etomidate as an injection.
Okay, the basic principle is whenever we are discussing the individual properties of the patient drug, we need to think that when you're using on the ground, on ground zero, when you are using a drug, the way in which you are using it, the adjuvants you are supporting, the precautions you are taking, your backup plans, plan B, everything matters. Just because you have a so-called safe drug, patient need not be safe. So whenever you have a chance to optimize the hemodynamics before venturing into an induction of GA, we need to do that first. So drug choice comes second. The modality of use matters most. Okay. Then for respiratory effects of etomidate.
Respiratory effect, it is also it does not have much effects on the respiratory system. Apnea is very rarely caused. If you have a rapid IV injection, the patient can go into apnea. Mean ventilation is slightly reduced, but respiratory rate is almost maintained. So it is a respiratory system. It is mostly safe using etomidate.
Okay. Fine. It does not cause histamine release. That is one of the advantages with etomidate. Now we'll speak about its disadvantage, the effect on adrenocortical system.
Yeah, that is the main issue while with etomidate, and all the derivatives that have been introduced is try to overcome the adrenocortical suppression. Because in case of sepsis patients and all, when the cortisol secretion is reduced, can have an adverse effect on the patient. So adrenocortical suppression is one of the most important hurdle of using etomidate in ICU setup or in as a maintenance infusion, because it can cause it is a more stronger adrenocortical suppressant than it is an hypnotic, because a very low concentration of etomidate can cause adrenocortical suppression compared to its dose required for a sedation or hypnosis.
That specifically inhibits the enzyme 11-beta hydroxylate. Okay, the suppression may be desirable from the standpoint of stress-free anesthesia, but beyond that, to support our system, steroids are definitely required, and the conversion of cholesterol to these steroids are vital for our patient survival. And unfortunately, the adrenocortical suppression outlasts by many hours or days after the hypnotic effects, sedative hypnotic effects have subsided. That's why etomidate has not been too popular given all the other positive effects with in the different systems. Okay, where all do we use etomidate?
Etomidate, like I said, it is for a cardiac disease patient, valvular heart disease, aortic stenosis surgery. It can be used for thoracic surgery, CABG, transluminal angioplasty. It can be used for cardioversion as a sedative. Okay. That is a cardiac situation. in case of also in neurosurgery, like I said, it can preserve the ICP or increase the ICP while maintaining the CPP. So neurosurgery like deep brain stimulation can be used for aneurysm surgeries. Also, etomidate can be used. Traumatic brain injury it can be used.
Okay. So there are some novel etomidate derivatives. If you are asked during the Viva, it will be nice to give the answers. So
yeah, there
just
are
be familiar
mainly
with. Yeah. Go ahead.
the most. Excuse me, I can't see the slide.
Okay. Yeah, different preparations, and one of the audience questions, we'll come back to the preparations at a later time. Okay. So we'll move back, and shall I go to the audience for your response, because I think you all will be keen to give your response. Shall I put the first question? Yeah, choose the single best answer. You will get a poll window on your screen. Your response will be anonymous. Don't worry about it. It's only about giving your feedback. Just click on the option which you think is correct. Which of the following IV induction agent is preferred in a patient with hypovolemic shock? Okay, the options are thiopentone sodium, option A, B, propofol, option C, ketamine, option D, midazolam. So I am putting the poll window. Yeah, single best response. I request, if possible, everybody to put in your answer, because your anonymity is retained. Learning process continues. Yeah, I'm happy that more people are attempting now. There is not much confusion. Dr. Faiz, do you think the question has been too simple for our audience?
Yeah, that's so.
Okay, for that, that's a warm-up thing. I'll put harder questions later. So 95%, there is no doubt that ketamine is the choice. Okay, so we are speaking about a patient with hypovolemic shock. Okay, so this is the property comparison among the induction agents. This is the chart given in Miller. It's regarding the change in cardiovascular system, especially when you are discussing about hypovolemic patient. Heart rate change. Ketamine basically stimulates the sympathetic systems and tries to bring up the heart rate and mean blood pressure. And of course, SVR is also coming up. But one point I would like to give is hypovolemia. Just because you have ketamine, don't jump on it. Try to do the fluid resuscitation, get the volumes corrected as much as possible. And again, remember that when the sympathetic reserves are exhausted, you may have to bear with the direct myocardial depressant effects of ketamine. So we need to be worried about that. And the nearest choice which will be competing with ketamine would be etomidate, in a situation where patient has gone into a hypovolemic shock. Again, the way in which you'll be using, the manner in which, the speed at which, or the manner in which you administer the drug also matters. Etomidate is a close contender for the choice of induction agent in a patient with hypovolemic shock because of these properties. Yeah, if you look at this chart, you can see the effects of major induction agents, thiopentone, propofol, and etomidate. Etomidate has no major inotropic depressant effect, no major venodilatation, cardiac output is reasonably preferred, heart rate change is reasonably preferred, and oxygen consumption is less. And compared to thiopentone, where there will be a depression of myocardium, venous dilatation, cardiac output comes down, heart rate goes up, oxygen consumption goes up, and definitely avoid if ischemic heart disease or hypovolemia is the dictum when we speak about thiopentone. Propofol, maybe because of our familiarity with the drug, people are using propofol, but with a caution, because we should be knowing that cardiac output may fall. We need to have the plan B ready before administering shock, propofol. Again, just to bring to your attention that shock itself is an anesthetic. This statement has been attributed to Richard Dutton, former chief of anesthesia at Shock Trauma, Baltimore. So basic building block of rapid sequence intubation is rock bar succinylcholine tube apology in a shock patient who is almost comatose, just to bring to your kind attention. Okay, so I hope that is clear. I think after the warm-up, we'll go to the second audience poll question before Dr. Sana gets ready for the next case scenario. Which of the following IV induction agent is not targeting GABA A receptors? Again, this is a single best response question. Option A, thiopentone sodium. Option B, propofol. Option C, ketamine. Option D, etomidate. Shall I put the poll window again? Sorry, the window was on. Yes. Yeah, poll window is there. We can choose the single best response, not targeting GABA A receptors. Okay. Yeah, we'll be closing the poll in 5 seconds. Thanks for your enthusiasm and response. Shall I end the poll? Yes. Again, I think it's been a simple question for our audience. Option C is the universal choice. Ketamine is the answer, because if you see the GABA receptor, you can find our friend etomidate, barbiturates, propofol. Ketamine is not there. It basically, even benzodiazepine acts through GABA A receptor, and ketamine acts mostly through the NMDA receptor, NMDA antagonism. We'll hear more about ketamine from Dr. Sana. Dr. Sana, you are with us?
Yes, sir. Hello. Am I audible,
okay.
sir?
Oh, yeah, fine.
Sorry for the inconvenience, sir.
It's okay, it's okay. We'll go to case number 4. 4 is already taken, sorry. Case number 5. Yes, a patient with porphyria comes for an inguinal hernia repair and is requesting a general anesthetic. Which induction drug would you choose? Or shall I make it the other way around? Which induction drug would you avoid?
Thiopentone.
Thiopentone you will avoid. Okay. Then we'll discuss about thiopentone now. That's the right answer.
Okay.
Yeah. You can go ahead describing thiopentone. The chemical properties, the class, the preparations. So whenever you are given a choice to pick up a drug, you can start speaking on that drug for 2 to 3 minutes if possible, uninterrupted, so that examiner also will get some time to relax. Okay, go ahead.
Okay. Thiopentone is a thiobarbiturate. It can be barbiturate, can be oxybarbiturate or thiobarbiturate, depending on the sulfur atom or oxygen atom at the second carbon atom. So thiopentone comes in a thiobarbiturate, which contains sulfur atom at the second carbon atom. Presentation is it is a hygroscopic yellow powder, and it contains thiopentyl sodium and 6% sodium carbonate. It is stored in the atmosphere of nitrogen. The drug is reconstituted with water. Hello, am I audible, sir?
Yes, go ahead.
Yes, okay. Go ahead.
It is reconstituted in water prior to use to yield a 2.5% solution. The pH of it comes about 10.8, whereas the pK of thiopentone is 7.6, and it is stable in solution for 24 to 48 hours. Main action is hypnotic, and it is also used as anticonvulsant agent. It acts primarily through GABA receptor. It binds to the GABA A and increases chloride ion conductance and causes hyperpolarization. Now, going to route of administration, it can be given IV.
Okay. How about the effects on various systems?
IV induction. For induction, the dose is 3 to 4 milligram per kg, and onset occurs in about 10 to 30 seconds. And again, if it is given as infusion, 50 to 100 microgram per kg every 10 to 12 minutes can be given. Now, for going to effects. In CVS, it causes a negative inotropic effect, and it decreases the cardiac output. There is a decreased systemic vascular resistance. Then, in the respiratory system, it is a potent respiratory depressant.
Heart rate change? How about the heart rate change?
It causes a reflex tachycardia.
Okay, that's a contrasting with the propofol.
Propofol.
Don't get
Reflex tachycardia.
Okay. Okay. Fine.
Respiratory system, it is a potent respiratory depressant. Apnea may occur following the administration. Then occasionally there can be laryngeal spasm seen.
Because it doesn't suppress the reflexes.
Doesn't suppress the reflexes.
Okay.
Ventilator pattern associated with the thiopentale is called a double apnea, where there is an initial apnea for a few seconds, followed by few breaths of reasonably good tidal volume, and again followed by more prolonged periods of apnea. This is termed the double apnea. In the CNS, it produces a smooth, rapid induction of anesthesia. Cerebral blood flow, ICP, and intraocular pressure are all decreased after the administration of the drug. There is a dose-related depression of cerebral oxygen consumption rate, and it also has anticonvulsive effect. Even though dose-related CMR O2 decrease occurs, it maintains a ratio of CBF to CMR-O2.
Okay, it has got protective effect on the focal neurological insults.
Okay.
Especially when you are thinking about the barbiturate coma for during the neuroprotective measures. Okay, other effects of thiopentone? Maybe side effects?
Side effect, it causes it has an garlicky or onion taste, and it causes anaphylactoid reaction. If it is accidentally injected to artery, it causes thrombosis. And to treat that, you can either dilute the agent, you can inject saline, or you can give a brachial plexus block, or you can even give heparin to prevent thrombosis. It should not be used in acute intermittent porphyria because it stimulates aminolevulinic acid synthetase.
Promotes heme synthesis.
It can cause local tissue irritation or necrosis. Hello, sir. Hello.
Yeah. Go ahead. Yes. Hello. Yeah. Go ahead, please.
Just go ahead.
It is better not to use when there is a respiratory obstruction or inadequate airway, because it may worsen the respiratory depression. And in case of severe cardiovascular instability or shock, it is better to avoid. It should be avoided in patients with status asthmaticus.
Okay, fine. So thiopentone being the popular induction agent is very popular with the examiners also. So you might get some questions on thiopentone, stock questions, I would say, because some of them you have already answered. pH of thiopentone reconstituted saline 2.5%. What is the pH for the audience?
10.
Yeah, 10.7. Some books says 10.5, 10.8. Can you describe the anti-analgesic property of thiopentone?
In subanesthetic doses, it increases hyperalgesia. It causes hyperalgesia.
It reduces the threshold for pain.
Threshold for pain.
Okay. We have already compared the analgesic efficacy of various IV induction agents. Thiopentone is anti-analgesics. Etomidate, benzodiazepines, no analgesia. Mild analgesia with propofol, and ketamine with intense analgesia. Okay. What is the safe anesthetic plan for acute intermittent porphyria? It's generally said that you can go for TIVA. Yeah, TIVA will be better. And should we avoid inhalation anesthetics? Yes. Can you comment on neurolept analgesia? Neurolept analgesia, I think during our entrance times, we would have read it. Neurolept analgesia. It's a combination of tranquilizer with an opioid. Okay. What is Innover? Innover is a combination of tranquilizer droperidol in combination with a potent analgesic fentanyl. Okay. Then what is neurolept anesthesia? Neurolept analgesia plus nitrous oxide oxygen. Okay, analgesia plus nitrous oxide oxygen gives neurolept anesthesia. Okay. So we finish with that. I think we'll go to the audience again. I think we have done only 2 questions, right? The third question for the audience. This is for the audience. Single best answer. Following are the advantages of ketamine as an induction agent, except option A, bronchodilation. Option B, profound analgesic properties. Option C, suitable in traumatic brain injury. Option D, an intramuscular route of administration in case IV access is not feasible. Okay, 4 options are there in front of you. So I am relaunching the poll now. The poll window is visible?
Yes, yes.
Okay. Yeah, fine. Yes. Now the audience is responding quickly. That's a good sign that they are active and involved in the discussion. So I'm winding up the poll now. If you want to put the response, another 5 more seconds. Yes. The verdict is clear now. Bronchodilation, yes. Profound analgesic properties, yes. If IV is not there, definitely you can give ketamine through intramuscular route also. But you need to, so the answer is traumatic brain injury. You need to be careful when you are using ketamine. But I would like to bring to your attention that literature is coming thick and fast on the use of ketamine in severe traumatic brain injury. This is one of the articles where the title itself says ketamine in acute phase of severe traumatic brain injury, an old drug for new users. It clearly mentions that ketamine might be considered as a potential drug to optimize analgesia and sedation in the management of mechanically ventilated patients with severe traumatic brain injury in association with other sedative agents. I request my PG friends to read through this sentence very closely. Then you will find that there are different conditions or background in which are mentioned in which you can use ketamine. Okay, it's a potential drug, yes. Optimizing analgesia, sedation, yes. In a mechanically ventilated patient with severe traumatic brain injury in association with other sedative agents. We are not mentioning about ketamine use as a sole agent. And we are not mentioning about the use of ketamine when there is a raised ICP with no other neuroprotective measures. You need to mechanically ventilate the patient. You need to hyperventilate, maybe to institute some other method to reduce the rise in ICP. Then you can give ketamine. It will give good analgesia that will settle down the stress response, which will be advantageous to you. So, and plus it's a reliable tool in the pre-hospital environment because it more or less maintains the airway reflexes and breathing. So pre-hospital scenario, things are slightly different compared to an acute care setting like emergency room or ICU. So this statement you need to read carefully, but until and unless more bigger studies are published, this may not appear in the recommendations per se, but for academic discussion, yes, there is definitely a place for ketamine in traumatic brain injury. I hope the message is clear. One more question for audience. Now we are going into recent advances. Okay, single best response again. The following drugs undergo hydrolysis by tissue esterase except. Okay, you need to pick up which is not undergoing hydrolysis by tissue esterases. Option A, remimazolam. Option B, midazolam. Option C, remifentanil. And option D, methoxycarbonyl etomidate, MOC etomidate. So shall I put the poll window again? Single best response again. Yes. Yeah, I'm winding up the poll. Yes. So 42% hits the right answer, which is midazolam. Okay, midazolam is the right answer. One second, I think I'll have to share my screen again. Yes. Okay. So remimazolam is a new ultra short-acting benzodiazepine, which we'll come to in a short while. Midazolam has no tissue esterases. Remifentanil is also there with tissue esterases, and MOC etomidate is there. Can you mention some more examples of drugs that we use as anesthetists undergoing hydrolysis by tissue esterases? You can put in the chat box. I'm waiting. Okay. One more at least, which undergoes hydrolysis by tissue esterases. Okay. Okay, here's the answer. That is esmolol. Okay. Just to keep in your buffer stock. Next question for the audience. Again, this is a multiple response question because there may be more than one true statement regarding flumazenil. Option A, it is a benzodiazepine ligand with high affinity, great specificity, and minimal intrinsic effect. Option B, for reversal of benzodiazepine effect, dose is 0.2 milligrams every 1 to 2 minutes up to the maximum dose of 3 milligrams. C, for reversal of benzodiazepine effect, if you are giving as an infusion rate 30 to 60 micrograms per minute. Option D, for diagnosis in coma, 0.5 milligram repeated up to 1 milligram. So again, I am putting the poll window. This time you can choose more than one option. Okay. Just click on whichever options you think is correct. Just for completion's sake, I have included flumazenil because benzodiazepine is in the scheme of events for today. Yeah. Okay, I'm ending the poll. Okay, more or less uniform response. 60% says A is correct, true. 77 says reversal of benzodiazepine. The dose is 0.2 milligrams every 1 to 2 minutes up to a maximum of 3 milligrams, correct. That's true. Option C, reversal infusion rate is 30 to 60 mics per minute. That is also true, but only 46% went for that. 51% when said option D is correct. Yes, Option D is also correct. Okay. So this is the flumazenil ampule vial, sorry. So just for familiarity. Okay. So audience, you can take rest. I'll go ahead with case number 6. I think Dr. Faiz.
Yes, sir.
Which induction drug lends itself well for use in a pre-hospital environment?
Pre-hospital environment. Is it dexamethasone?
No, pre-hospital environment.
Should be benzodiazepine.
Pre-hospital environment, war surgeries, on-field surgeries. I thought the answer will be obvious. It's ketamine. 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 Ketamine is the choice because it protects the airway reflexes. It doesn't blunt the breathing. And it's an intense analgesic, so we can supplement analgesia. So, Dr. Sana, can you comment on ketamine, chemical properties?
Yes, sir. Ketamine, it is a phencyclidine derivative. It comes as a colorless solution containing either 10 milligram per ml or 50 milligram per ml or 100 milligram ml racemic mixture of ketamine hydrochloride. It can be a mixture of equal proportion of S plus isomer and R minus isomer of ketamine. And mostly all the preparation that we have available contain 0.1 milligram per ml of benzethonium chloride as a preservative. Okay. Main action is it causes a dissociative anesthesia.
Okay. Can you explain that? What is dissociative anesthesia?
That means a patient who receives ketamine only as a sole anesthetic agent, they'll be in a cataleptic state. All other intravenous agents will be causing a normal pattern like normal sleep. Okay. These patients who receive ketamine as sole agent will be in a state of cataleptic state.
Cataleptic means they'll be keeping their eyes open, but
eyes open,
they'll be in a different world without their proprioception, their limbic position. There is dissociation between thalamocortical and limbic system, basically. Okay.
Limbic system.
So, can you quickly go through the effects of ketamine on various systems?
Yes, sir. In the CVS, it causes tachycardia, and there is an increase in blood pressure. Okay. There is an increase in central venous pressure and cardiac output, secondary to increase in sympathetic tone. But ketamine, directly it is a myocardial depressant, but this effect is overcome by the other direct sympathetic tone effect. Okay. It is reduced with pure S plus enantiomer of ketamine. But the baroreceptor function will be maintained in case of ketamine. Respiratory system.
Okay, it increases the myocardial oxygen requirement, so should be used with caution in ischemic heart disease patients.
Heart disease patients.
Okay, CNS.
CNS, it causes a dissociative state that is okay. Functionally separating thalamocortical and the limbic system. Okay. The eyes may remain open. There may be pupil dilatation, nystagmus, yes. Hypertonus can occur. Cerebral blood flow, cerebral metabolic rate, and intracranial pressure and intraocular pressure are all increased. Okay.
It may have a possible anticonvulsant action also. It can precipitate the convulsion also. Dissociative anesthesia, we have already mentioned. How about the emergence delirium?
Patients who receive this ketamine will show emergence delirium. That is, they'll have unpleasant dreams and hallucinations.
What is the mechanism? Okay, so misinterpretation of auditory and visual stimulus and loss of proprioception, loss of skin musculoskeletal sensations. Sorry, I am hurrying through because we are running short of time, I think. Okay, there is a potential role for ketamine interaction with opioids.
Opioid receptors.
Okay. How about the incidence? Which are the vulnerable population for emergence delirium?
It is more seen in females than males, and it is more seen in adults compared to pediatrics.
Okay, age above 15, female gender, dose of ketamine more than 2 milligrams per kg IV, history of personality problems occurs less frequently when ketamine is used repeatedly, like when the patient gets exposed to ketamine for repeated burn stressing or repeated surgeries. No significant long-term personality differences as per the literature. How do you prevent it?
You can use benzodiazepines, midazolam along with ketamine, which will prevent occurrence of emergence delirium.
Okay. Hello. Okay. Fine. You need to administer it well in advance, maybe at least 5 minutes prior to giving ketamine. And maybe you can go in for a combined plan, what is called as co-induction, where we mix more than one agents and maybe add opioids in our armamentarium so that the total dose of ketamine is also reduced. I mentioned that the way in which, the manner in which you use each agent matters. Okay, this is a favorite question you might be asked on these things. And respiratory, no major depression of ventilation. That is an advantage we are utilizing in the pre-hospital setting, where we may not get full-fledged respiratory support. Yes. Yeah, go ahead.
It acts as a smooth muscle relaxant and it improves the pulmonary complaints.
Okay. The drawback is salivary and tracheobronchial secretions are increased. It has a bronchodilatory activity.
It is better to give a glycopyrrolate before
anti-salagogue and benzodiazepine pre-medication before we take up ketamine is important. Okay, fine. So we'll move ahead. Can you describe quickly on midazolam?
Yes, sir.
Sana? Yeah.
Midazolam is benzodiazepine. Again, benzodiazepine receptor agonists can be divided into short-acting, intermediate-acting, and long-acting. Midazolam comes under the short-acting group, and the long-acting is the diazepam, and the intermediate-acting is lorazepam and temazepam. Midazolam is a water-soluble imidazobenzodiazepine. It comes as a clear colorless solution of midazolam hydrochloride, which contains either 1 milligram per ml or 2 milligram or 5 milligram per ml. It acts on the GABA receptor and it mediates inhibitory synaptic transmission in CNS. It enhances the response to GABA by facilitating the opening of GABA-mediated chloride channel and resulting in hyperpolarization. There is another protein called translocator protein, which is described as a peripheral site for action for benzodiazepine.
Okay, quickly go through the effects of midazolam on various systems.
Okay. In CNS, it causes dose-dependent depression. There is anterograde amnesia associated with. All BZDs have hypnotic, sedative, anxiolytic, amnestic, anticonvulsant properties.
Okay.
Intrathecal, if you give midazolam intrathecally, there is excitatory GABA-mediated transmission in interneurons, which will lead to decreased excitability of the spinal dorsal horn neurons.
Okay.
That will improve perioperative analgesia and reduce nausea and vomiting. It reduces the cerebral metabolic O2 rate of O2 in dose-related manner. And it will maintain a cerebral blood flow to CMRO2 ratio.
Okay.
It has a neuroprotective effect by preventing lipid peroxidation and mitochondrial damage.
Okay. CVS?
CVS, it is relatively cardiostable.
But again, you
there is
need to be
only,
cautious in hypovolemic patients.
there is only moderate decrease in arterial blood pressure resulting from decrease in systemic vascular resistance.
Okay, can you quickly comment on the uses of midazolam?
Okay, midazolam can be used for induction of anesthesia, for sedation of like endoscopic procedures as sedative agent you can use. It can be used as hypnotic. As pre-medication, it can be used like orally. It is 7.5 to 15 milligram for midazolam.
Okay.
It can be even given intranasally, 0.025 milligram per kg.
Okay.
It can be used to prevent post-operative nausea and vomiting. Can be used in ICUs for ICU sedations.
And has anticonvulsant action.
Anticonvulsant action.
Either as infusion or.
Bolus.
Okay. Then comparison of different benzodiazepines. These are the charts in Miller and Stolting pharmacology. You need to go through that. Because of shortage of time, I am skipping through. Remimazolam is an ultra short-acting benzodiazepine for IV sedation. Okay, it has got high clearance by tissue esterases. I think our audience, people are familiar with this tissue esterases metabolism. It acts on GABA A receptor. It is close to the ideal sedative drug due to its fast onset, good sedation, and fast recovery time. But still, more studies are awaited to find the best dose in different clinical scenarios. That is with regard to remimazolam. Shall I quickly go to Dr. Faiz for a brief description on dexmedetomidine?
Yes, sir. Dexmedetomidine is the S isomer of dextroisomer of medetomidine. It's an again an imidazole derivative. It's a very pH. It's a very isotonic water soluble drug. Its pH is of pK values of 7.1. It's a sedative, hypnotic. It's an alpha 2 agonist. That is the first thing you have to say.
Yes.
It's a alpha 2 agonist.
Highly specific alpha 2 agonist.
Alpha 2 agonist. Previously, it was used as clonidine was the alpha 2 agonist used in the market, but it is more specific, more alpha 2 specific. Ratio of 1,600 is to 1 for dexmedetomidine compared to 220 is to 1 for clonidine. It has action is on a different system, but it is mainly a sedative, hypnotic, analgesic, and anxiolytic property. The action in the it's a very going into pharmacokinetics. It's mainly completely metabolized by glucuronidation and methylation, and CYP2A6 metabolism also is involved. And as a result, the glucuronide and the methyl conjugates are excreted by the kidneys. In case mostly hepatic metabolism. In case of hepatic disease, this metabolism may be reduced, and in case of a severe renal disease, the plasma protein binding may be reduced, and as a result, there is an increased free drug available, and the sedative action of the dexmedetomidine in a renal disease patient will be very intense. Intense sedation will be there in such patients. Going into the effects on the system.
Yes. Yeah. How about what is special about dexmed? Yeah, well, what is special about dexmed?
Dexmed is a sedative, hypnotic, anxiolytic, analgesic drug all in one.
It acts through the endogenous sleep promoting pathways,
I'm
generating natural sleep pattern so that there is no rebound reaction when we stop dexmedetomidine, and the erosibility is also better.
Very better.
Yeah.
Its action is on the locus coeruleus, and the projection from the locus coeruleus to the other areas of the brain is reduced, and as a result, the patient has a very natural sleep pattern and also very easily arousable, and the patient will be less agitated and on arousal, and as a result, this can be used in ICU sedation because this reduces the ICU stay. Then the duration of mechanical ventilation can be reduced, and that is a
delirium is also reduced.
Or post-operative, when cognitive dysfunction is also reduced as a result of this.
Yes.
Going into the analgesic action, it has it reduces the pronoceptive transmitters like glutamate and substance P will be reduced. It has an opioid sparing effect. The MAC of the anesthetic can be reduced. It has alpha-2 receptors are present in the spinal cord, and the pain perception towards the brain is reduced. It also causes hyperpolarization of the interneuron. All this has an analgesic effect, and for this we are using this dexmedetomidine as an adjuvant off-label use in central neuroaxis blockade and also in peripheral nerve block, which has a prolongation of the sensory effect, that is the A delta C fibers, and also somewhat prolongation of the motor fibers also. That is the action in the central nerve system. It also has a neuroprotective effect, like it reduces the intracranial catecholamine surge in case of trauma, and also pro-apoptosis and anti-apoptosis modulation will be better. It also has a neuroprotective effect. That is one of the CNS effect. Going into the respiratory system, it has a minimal effect on the respiratory system. Dose-dependent slight reduction in mid-ventilation will be there, but mostly it does not cause any apnea. And as a result, these patients can also have this hypercarbic arousal phenomenon, similar to that of a normal sleep pattern. That is, when there's a hypercarbia, the patient itself gets aroused from the sleep. That is the effect on the respiratory system. Going into the cardiovascular system, it has a biphasic action. When you give a very large loading dose, like 0.5 mcg per kg as a loading, or a 1 mcg per kg loading dose, the patient can have a transient increase in BP. That is, they'll have a hypertension. Hypertension response is because of the action of the dexmedetomidine in the peripheral alpha-2b receptors, which is a vasoconstrictor. So it goes and directly acts on the alpha-2b receptors, and the result, it causes vasoconstriction, which causes increased SCR and result in increase in BP. It can, because of the decrease in the catecholamine surge, especially norepinephrine release will be reduced by the pre-synaptic alpha-2 receptor agonism. There is a decrease in the catecholamine surge, which causes reduction in BP, and it can also cause bradycardia. So in case of you need to reduce the chance of hypertension, we can avoid the loading dose, or we can actually reduce the loading dose less than 0.4 mcg per kg. This is the main action on the cardiovascular system.
Can you mention the doses also?
The loading dose usually given is 1 microgram per kg, and infusion dose is 0.3
that should be given over 10 minutes, which is important.
Okay, 10 to 20 minutes. You can actually increase the duration to more than 20 minutes. We can reduce the chance of hypertension. And the maintenance dose is 0.2 to 0.7 mcg per kg per hour. We can also use this in procedural sedation, especially in children with needle phobia. You can use this as an intranasally or buccally. It has a very high, almost 20% of bioavailability. You can use 3 to 4 mcg per kg intranasally in children. It is used as an off-label use in CT-MRI, pediatric CT-MRI for immobilization of children.
Okay, one more thing I'd like to highlight is for facilitation of awake fiber optic intubation. We can use it because it provides sedation, dry mouth, and preserves ventilation, which all will be helping you in your awake fiber optic airway management. While FDA approved the use of dexmedetomidine infusions for 24 hours or less, multiple studies have shown the safety of using this agent for longer period, even up to 30 days. So we need to wait for longer, larger studies to come up to go to an extent of recommendations. I think we'll go to the last question for the audience. This is again a take-home message kind of thing. I would like all of you to attempt this method or methods of avoiding accidental awareness under general anesthesia during IV induction. You have to pick up the true statements. Pre-medication with amnesic agents. Use more than the minimum dose of intravenous agent to induce unconsciousness. Avoid neuromuscular blockade whenever possible, and if used, avoid complete paralysis. Use volatile agents at more than 0.6 MAC in tidal with nitrous oxide, or more than 0.8 MAC if used alone. So again, multiple response. The poll window is appearing now. accidental awareness under general anesthesia. So far, we have discussed how to make the patient sleep, but the last point we are exploring, is there a possibility of our patients being awake during this process? Yes. I'm winding up the poll now. Responses are coming, but we are running short of time. Sorry for that. Okay. I think 79% agree that premedication with amnestic agents like benzodiazepines can avoid unintended or accidental awareness. Yes. 47% says you give an extra dose, more than the minimum dose. Don't stick to the per kg calculations. You give a little bit of extra to avoid accidental awareness. 47% says yes, but it's a true statement. 45% says avoid neuromuscular blockers whenever possible, and when used, avoid complete paralysis. This is a key message. The moment you paralyze the patient, you will not be able to get any clinical clue to the depth of anesthesia awareness. So sparingly use neuromuscular blockade. Yes, and indicated you have to use it, but titrate it to the best of the use. Option D, 71%. This is the second most popular. And this is also a true statement. Actually, all the statements are true because you need to maintain at least 0.7 to 0.8 MAC. And this is one message, like all our induction agents will peak fast. Also, the peak will come out fast. So if you are opening your dial in the volatile vaporizer, the value creeps up slowly. So there will be a gap when the patient doesn't have an adequate serum level of intravenous agent and doesn't have enough MAC by the inhalational agent. So generally it's mentioned as mind the gap potential. I hope the message is clear. You have to keep in mind this possible potential gap where your patient may be accidentally aware during the procedure. I think I tried to cover all this during the stipulated time. And even the module 1, if you have module 1 drugs, we have discussed neuromuscular blockers and reversal agents. We are free to discuss any controversial topics or whatever concepts I have tried to put across during module 1 and 2. I'll be happy to take your queries on my email also. This is the website I'm managing, Online Anesthesia Tools. I again thank both the PG delegates who were actively participating during this session. I've tried to make it interactive and streamlined to their objectives. I've tried to present the drugs viva on a case scenario format. It's back to you, Nasser sir.
Yeah, Dr. Sanis, you have made a boring topic much interesting and much interactive. Thank you for the excellent way of presenting the matters.
Thank you very much, sir. I hope I haven't exceeded the time.
That's fine, because everybody was being part of it very actively. And one or two points I would just like to add. One is that this thiopentol, which we were using during our PG time, and there most of the senior teachers will be emphasizing on its histamine release. That's a very important part because it has got a significant histamine release and can cause bronchospasm and all. And the second thing, the same drug was used as an infusion. I don't know the present scenario, as an infusion, as an resistant conversions, and as an anti-convulsant. In resistant conversion patient on ventilator, it has been used as an infusion. Even for children, it has been used, right, sir?
It's part of barbiturate coma, I think, neuroprotective regimen. Even I think interactive cases, we are still using barbiturate thiopentone infusion in some centers, I think, because technically it produces protection in the penumbral region cells, so that the suppression of cerebral activity ultimately gets translated into a protective action.
And another point which stuck to my mind is the effect of propofol in the intraocular pressure, which is much better than thiopentol or any other drugs because it reduces the IOP much than any other agents, right? And maybe the same drug you require for a higher dose in children, propofol. That's a part which they must be very, very cautious about. The dose is not same because of the large body volume, central body mass and all, you require a higher dose. That's
Actually,
all from
I
my
wanted to put into that endpoint of induction, but it's slightly controversial. There is no universal consensus. And now in the era of BIS and other neuromonitoring, probably people will tend to go to a clear-cut answer like you titrate to BIS like that. Previously, there were some clinical endpoints like loss of response to verbal stimulus, eyelash reflex, loss of ability to hold an object like that. So those things are also there, but it's an exhaustive topic. IV induction agents, it's an exhaustive topic. And I think both our postgraduate friends have done well, prepared well, and they have presented well. Thank you very much.
Thank you, Dr. Sanish. You have made the boring topic very interesting with the case scenario and the poll or audience polls. And Dr. Nasser for preparing the postgraduates well. And before going for the questions in the chat box, there is a few announcements. One is next week. Next week, we have a topic on a case discussion on carcinoma of breast, post chemotherapy for mastectomy. This is a postgraduate resident from Regional Cancer Center, Trivandrum will be presenting. Our internal examiner will be Dr. Venugopal, Professor of Anesthesia at RCC, and our external examiner will be Dr. Rakesh Garg from AIMS, Delhi. And another announcements is those postgraduates who are not yet joined can send their message. Any of your friends, you can ask them to send their message to this WhatsApp message to this number 90376 indicating their name and college. And now we have certificate distribution, and there are some pending certificates also. And first, I will call upon Dr. B. Paurnami. She has presented an X-ray test on 13/3/2021. Dr. Paurnami, it will be sent to their email address. You can accept the certificate from the ISA, Kerala State Branch. And next, Dr. Arfan Ahmad JS. He has also presented the X-ray test on 13/3. And please accept our certificates, Dr. Arfan. Next, we have Dr. Rubia Said. She presented obstructive jaundice. That was a case discussion on 24. Congratulations, Dr. Rubia Said. And next, we have Charuda Ullas. And he has presented a topic on muscle relaxant. That was drugs in anesthesia part 1. It was by Dr. Sanish PJ. And along with Dr. Charuda Ullas, there was Minu Rose on 33/4. That was drugs in anesthesia part 1 muscle relaxants. And now today's postgraduate students, Dr. Fatimat Sana, postgraduate student from KIMS Al Shifa. Congratulations, Dr. Fatima Sana. You have answered well and you have prepared well, both the Dr. Sana and Dr. Firas Hamzat. Congratulations, Fayaz Hamzat. Congratulations, both the postgraduate students. And once again, congratulating Dr. Nasser for preparing the students well, and Dr. Sanish PJ. Thank you, Dr. Sanish PJ. And we'll go to questions. Any questions in the chat box? Can't see any questions in the chat box.
It was disabled, Rajesh. Hello.
Oh?
The chat box was found disabled, I think. So I could nobody could post anything. I think so.
Answer.
No, there was posting from Dr. Sanish, Venkatagiri, everyone has posted.
Okay, okay, oh, okay. Yeah, because it was seen that disabled, so I could not post anything. Okay, okay.
Answer, I want to talk something.
Yes,
Any
sir,
comments
please.
from the senior faculty members?
Yes, Gadu sir, please.
Yeah, this is for Sanish. Can you hear me, Sanish?
Yes, sir.
I think there is a proper protocol to be followed when you are giving intra-arterial thiopentone. That has to be covered all points. You just cannot just say that I will give this brachial plexus block and all those things. The proper protocol has to be followed, that keep the way, I mean, IV, that is the intra-arterial needle in situ, etc. This is a proper protocol. Same thing about the propofol. I wanted to say, there is a very important, interesting question about the big study that was being done about 2% propofol, which is a very important thing that has to be covered, because quite often that has been asked that why 2% is being used, why not 1%? If it is an IV sedation to be given, why I can't give 1%? Why I want to give 2%?
Okay.
That has the answer has to be told properly.
Another comments? Hello?
Yeah.
Dr. Sanish?
Rajesh.
Hello? Dr. Sanish?
Yes.
So nowadays ketamine is given, there is a lot of article, ketamine is given for intractable fits.
Yeah.
So we are called upon sometimes to give intractable as ketamine for intractable fits. And we have done around 4 to 5 cases we have already given. And there are a lot of off-label prescriptions for ketamine also. I will share the article with you and to the audience also. And is stellate block useful to in the event of any accidental intraarterial injection of thiopentone? Any comments from Professor Gedu and Dr. Sanish?
Yes. But the thing is, before that, I will love to go for a proper protocol that you first thing keep the needle in situ. Thereafter, you just flush it with a normal saline, and thereafter, I will prefer to give a local, either maybe vasodilator, or in case want, I can just give a hyaluronate so that it can dilute the vessel, the drug. Thereafter, I will give for a IVRA regional anesthesia also can be done, whereby I will give a ganglion blocker, that is either phentolamine that can be given in the drug, which is preferred. And in case all those things fail, then instead of brachial plexus, I will be more happy to go for a stellate ganglion block, because stellate ganglion is concerned with the sympathetic, not the brachial plexus. I entirely agree with you.
Thank you.
Hello, Sanish.
Yes.
Hello,
Yeah.
Sanish.
Yeah, please.
Yeah, I want to ask one or two small questions. I want to clear some doubt regarding the role of egg phosphatide. What is the actual role of egg phosphatide in propofol infusion, the propofol preparation? One thing. Second thing, what is the reason for hiccups? Many times we see hiccups following propofol induction. So, is there any definite reason for that hiccup? And then regarding ketamine, what is any studies came regarding the long-term use of ketamine and learning disabilities in children? Because we give ketamine for radiation for children for 20, 30 fractions, 20 days, 30 days we give. Small dose only, probably small dose. But does it have any learning, any problem with learning disabilities in children? I want to know that. Any literature is available on that?
Sir, actually, I'm not ready with a answer for this question.
One more ketamine use I can tell you before he talks. I think this can add up some knowledge to you also. That ketamine is being used as one of the prevention methods for the patients who have become opiate addict. So this has been used in that. One more that is addition that has come up of late is either we give subcutaneous or even oral ketamine. These are being used for opioid addict or also for the neuropathic pain. This is being used for these drugs, these conditions also.
It's also used for many chronic pain syndromes also.
No, that's what I'm saying. It is for the opioid addict patient or for the patient who has got a neuropathic pain element.
So maybe you have got a cancer pain syndrome with a neuropathic element. In that condition also, ketamine is being very useful.
Okay.
I think Dr. Rajesh, as you mentioned, status epilepticus, what is mentioned was if the status is not controlled in time, the chemical milieu changes and it becomes refractory to regular anticonvulsant drugs. Then at that point, actually the focus shifts to drugs like ketamine, which may be more effective in that chemical milieu, and maybe that will be better. That may be one of the options to control the status epilepticus.
Maybe the reason, but we are we are often called, sometimes called to give ketamine infusion. Okay,
Same,
thank you,
same
Sanish.
with the status asthmaticus also. Like it's one of the options later down in the algorithm where we can try out the bronchodilator property of ketamine also in intractable bronchospasm also.
It's emergency physicians use left and right in their emergency casualty scenario, because maybe because of analgesic, excellent analgesia, because they use subanesthetic doses only.
Yes. Even for labor analgesia, people are using, I think, especially when patient appear more towards the second stage, where we may not get enough time for other options like epidural or to educate them regarding Entonox. This is one of the options. May not be the best option, but it's been used.
And keep propofol is also a combination with the propofol is also a now popular agent along with dexmedetomidine also, ketamine with dexmedetomidine, especially for short procedures.
Another thing is ketamine is underused. I think probably in the OTs, small procedures like biopsies, like bone biopsies, small incision biopsies can be done under ketamine. But people are using, they are giving either putting eye gel or endotracheal tube. So ketamine people are not, our newer PGs are not all using. I think so. Hello.
And there is as far as I know, there is no conclusive studies proving that anesthetics negatively affects on the developing brain. Have you noted? That's what I have seen so far. Any comments from the senior faculties?
Because we use a lot of ketamine for children for coming for RT. That is why I asked that question regarding any learning disabilities has come regarding use of ketamine in children. We should use ketamine in the OT, but OT it is less utilized. That is, I want to tell the postgraduates, because it's a very good drug, for a short procedure like INDs and biopsies can be done under ketamine anesthesia. Just ketamine, and it's good. There's no need for any reversal, anything. One single drug with glycopyrrolate and midazolam will do the purpose. Will serve the purpose. So it should be utilized in the proper way in real needs.
Okay.
It was excellent presentation by both Baburaj sir and Sanish. It was excellent.
Dr. Baburaj, any comments? Dr. Baburaj?
Yes. Now, regarding oral ketamine, this is a very useful drug which we use in chronic pain therapy, as Gadu sir said. We are making use of NMDA antagonism. So we give oral ketamine. Usually the same IV preparation is given as oral preparation, and usually 10 milligram Q6H or Q8H is given.
We used to mix it with fruity.
Honey or fruity. The taste is sour.
Thank you, Dr. Baburaj. Thank you, Dr. Baburaj, for the excellent presentation also. And over to Dr. Binil. Dr. Binil?
Yes, I think I can take our Bill is already engaged in another meeting of SARC.
Yeah, sir.
Okay,
I am here.
No problem.
Just come on time.
He is attending both.
So before winding up, I would like to thank all the faculties joined today evening. Dr. Baburaj and Dr. Sanish PJ for their excellent presentations. Actually, they are stalwarts of the field. I don't have to introduce them or mention their experience and all. They are our pioneers in the field for the presentation also. So I thank Baburaj sir and Dr. Sanish for presenting today's topics. And I extend my sincere thanks to Dr. E.K. Abdul Nasser, our president, for joining us today and preparing the topic with his PG students. Dr. Sana and second person was Dr. Fiyaz Ahmad. So I thank today's PG students, Dr. Fiyaz and Sana, for joining us today evening. I extend my sincere thanks to our president-elect, Dr. Venkatagiri, for joining us today evening. I also extend my sincere thanks to Dr. Vijish Venugopal and Dr. Rajesh MC, our coordinators, for chairing the sessions. And I thank all our participants, today's participants, for joining us today evening for the session. And thank you. Shall I close the meeting, sir?
Yes, yes. With the permission of the chairs, we'll close the meeting.
Yeah. Rajesh,
Okay.
sir, shall I close?
Yes, Benny. Thank you. Thank you, Dr. Benny.
Okay, thank you all. See you.
Thank
Good
you very
night.
much.